We are live now.
Good evening and welcome everyone to DOS-PEP. And today, as you all know, we are in the Strabismus and Neuro-Ophthalmology module, and we are currently running the 26th class. And we have an eminent speaker with us, Dr. Anita Ambashta, who will be talking about facial spasms. Our moderator for the session is Dr. Gunjan Saluja, who has done her senior residency and post-graduation from prestigious RP Center for Ophthalmic Sciences, AIIMS, New Delhi, and she is working as a consultant in strabismus, oculoplasty, and neuro-ophthalmology at present, has over 50 publications in various national and international peer-reviewed journals, and is also the assistant editor for the Indian Journal of Ophthalmology. Our speaker for the day is Dr. Professor Anita Ambashta, who's in charge of neuro-ophthalmology services at Regional Institute of Ophthalmology at IGMS Patna. She has presented papers at various national and international conferences and is a part of the ARC AIOS teaching program and is involved in the IZOG, WAS, and ACOIN PG teaching programs. She has over 40 publications in peer-reviewed journals and is also the recipient of various awards, including the SD Atharwal Award for Best Paper in Neuro-Ophthalmology, Dr. Ajit Sinha Award for Best Paper, and Best Research in IGMS Award for the year 2024, and so forth, and so multiple various awards similarly. She's also a reviewer in the Springer Nature and International Ophthalmology, iQuest, and Curious. On that note, ma'am, we welcome you for your talk on facial spasms today, and I'm sure residents will definitely benefit out of.
Thank you so much, Dr. Pranita. Can you hear me?
Yes, ma'am, we can hear you. You can start sharing your slide, ma'am.
Yeah, thank you to you and your team for inviting me for this talk. So I'll be talking on facial spasm, an ophthalmologist diagnostic crossroad. Crossroad because it is at the crossroad of neurology and ophthalmology.
Ma'am, we cannot see your slides yet. If you could share your slides first.
You can't see my screen?
No, we can see you, ma'am, but we cannot see your slides as of now. You can click on share and share your screen.
Just a sec. Can you see now?
Not yet, ma'am.
I've shared it.
If you can click on unshare and then reshare it.
Just, okay. Can you see it now?
Not yet, ma'am.
I have shared it. Where do you think? Can you see it now? No.
Not yet, ma'am. If you can just click on share and share your entire screen desktop and then go on share again.
See, there's share written on the right side and I'm sharing it from there.
If you click on share, you'll see a next button that will pop up.
Can you see it now?
No, ma'am.
Oh, God. It's in the right corner, the share thing is coming there. Or just give me a minute. Let me get some help. Just give me a minute. Not able to share it.
तो Zoom meeting का है तुम्हारा?
इधर ही तो है. It's here.
Just a sec.
We can see your screen, ma'am, now. You can just make it full screen and unmute yourself. Yeah. Yes, ma'am.
Yeah,
We
can
can
you hear
hear
me?
you, and the screen is also full screen. We can see that. You can.
Okay, thank you so much.
Yes, ma'am.
So I'll be talking about facial spasm and ophthalmologist diagnostic crossroad. Crossroad because it is at the crossroad of neurology and ophthalmology. So we don't see many patients of facial spasm, coming to our OPDs. And so according to some reports, a patient would probably go through four ophthalmologists or four physicians before he's finally diagnosed. And these patients are having a lot of problems because they might be having some functional blindness in between the spasm. When they're having the spasm, they're probably not able to see at that time. Plus, to be having spasm all the time must not be a good feeling. And so it's imperative that we learn to distinguish between different facial spasms. We know what are the red flags and how to manage these patients. So in this presentation, I'll be talking about the different types of facial spasms, how to distinguish between them, the red flags, and the management. So a little bit of the anatomy. So in facial spasm, the muscles which are involved of the face will be the zygomaticus, the orbicularis oris, plus the eyelid closure is caused by the spasm of the or by the contraction of the orbicularis oculi, the pretarsal, the septal, and the orbital part. So when the lid is being tightly closed, it is basically the septal part of the orbicularis oculi which is working. Along with that, the inhibition of the LPS lifts up the lid, but it's the inhibition, which helps in closing the lid. Apart from that, we have got the voluntary and the involuntary eye movements. The voluntary eye movements, which is initiated along with some neural connections between the basal ganglia and the frontal motor cortex. So all this together the activity between all this leads to facial spasm. Now, the nerve which is the trigger for all this, the nerve which is the trigger for the facial spasm is the facial nerve, which is innervating the orbicularis oculi and the muscles of the face. So a little bit about the course of the facial nerve. The facial nerve in the temporal bone in the facial canal, and then it exits the skull through the stylomastoid foramen and then divides into branches in the parotid gland and supplies the various muscles of the face and the orbicularis oculi. So it's a trigger of this. It's this nerve which is responsible for all the facial spasm and the different kinds we are going to see today. So what is facial spasm? It's an involuntary, intermittent, or sustained contraction of muscles supplied by the facial nerve. That is the seventh cranial nerve. It can also be associated with muscle spasms of motor component of trigeminal or hypoglossal nerves in whose vicinity this nerve is. That means that sometimes along with contraction of the muscle supplied by the facial nerve, we can also have contractions of the muscles involved in mastication or the chewing movements, the mastication. So what are the different types of facial spasms? We have got hemifacial spasm, blepharospasm, facial myokymia, tic disorders, and synkinesis. Hemifacial spasm, the key feature is that these are involuntary tonic-clonic contractions. These are unilateral. Blepharospasm, which is a bilateral spasm of the orbicularis oculi. Again, this is bilateral. Facial myokymia, which are fine rippling movements. Again, this is usually unilateral. Tic disorders, which are suppressible voluntary components, unilateral or bilateral. Synkinesis is usually, it can be unilateral or it can be bilateral, mostly unilateral. So we can see from this list that it's blepharospasm, which is mostly likely to be bilateral. And another important thing that we're seeing here is that most of this, the hemifacial spasm, the blepharospasm, the myokymia, these are all involuntary movements. And tic disorders, these are voluntary. So this is a difference. These are involuntary. This is a voluntary component. And synkinesis happens, when there is a facial nerve injury, and then there is a nerve injury, and then the nerve regenerates, and then it ends up supplying the femoral muscles. And so when one contracts, the others also contract. And so when this happens in one half of the face, this can lead to a hemifacial spasm also. Now, this is a very famous hemifacial spasm that we all know of. But was it really a true hemifacial spasm? I think we all know this picture. Well, no, because this was voluntary, not involuntary. This was voluntary. So it was not a true hemifacial spasm. So this can be unilateral or bilateral, suppressible or non-suppressible. Unilateral, we have the hemifacial spasms or the orbicularis myokymia. Bilateral, we have the blepharospasm, the dystonias. The suppressible ones, that is the tics. The non-suppressible ones, these are the true spasm. I think many of you would be knowing tics. In our childhood, we used to play a game called murder in which one person would be winking and the others would say, okay, the others had to find out who was winking. And one of the little fellows, he had this tick of winking all the time. So, he would get scolded all the time that why he's winking all the time. So after a lot of scolds, he was able to suppress it. So although there's an intense desire for repeated behavior, repeated contraction, but this can be suppressed. Types of facial spasms on the basis of the quadrant which is involved. So you have orbicularis myokymia in which just one quadrant is involved, in hemifacial spasm in which half, blepharospasm in which one half, the upper half of the face is involved, and in Mead syndrome in which the whole face is involved. So what is eyelid myokymia? We see it all the time. It's something which is very commonly seen in medical students. Is unilateral, the lower eyelid is involved. Usually it's benign, self-limiting. It usually just goes off. It's induced by severe fatigue, stress, exertion, a lot of coffee, and it rarely progresses to involve additional muscles. So this is an example. So you can see this flickering movement. The important thing is that, the eye is not closing along with this movement. The eye was not closing with these little flickers and sleep, this becomes okay. So this usually looks very benign and we see it all the time. But sometimes there are certain red flags. So when do we have to look more into it? If this twitching doesn't seem to end, it lasts for several weeks or months despite conservative management, or the twitching spreads to other facial muscles, or the spasms become severe, or there are associated symptoms like eyelid drooping, redness, swelling, or changes in vision. Sometimes they can be secondary causes, like they can be a demyelinating disease or a storage disorder, or something even more local like a radiation. The patient might have had some radiation or some trauma when some axon has just been caught up in some fibrous tissue. That can also lead to these twitches. So although it looks very benign, but we have to look for red flags because we, as ophthalmologists, are supposed to differentiate the primary from the secondary. Another disorder of facial spasm is the hemifacial spasm. So this is the movement disorder of muscle supplied by facial nerve. It's progressive, involuntary, irregular, clonic or tonic movements are there. It can be primary, mostly it is primary, but then it can also be secondary. And it typically starts around the eye, it's strictly unilateral, and it persists during sleep. But this is very important that it persists during sleep because it is going to help us differentiate from other conditions, which become better with sleep. Now, this is one video of, how do I? So you can see, this is a patient with a hemifacial spasm. You see the spasm? The spasm is sort of, tilting the angle of the mouth to one point. So this is the hemifacial spasm. You could see the spasm around the eye also. Left side is more commonly affected. And if it occurs at young age, then we have to rule out underlying conditions. And we also have to rule out all these spasms. They increase whenever there's psychosocial stress, whenever there's emotional upheaval, or so all this adds to the intensity of the spasm. Now, the important aspect of this hemifacial spasm is that there might be a neurovascular conflict, which is leading to this hemifacial spasm, and we have to rule that out by different imaging methods. For example, here, So this is a picture of the facial nerve being compressed by the anterior inferior cerebellar artery. There's a loop of the artery there which is compressing this nerve. So this compression can lead to the facial nerve leading to contractions of the one half of the face and leading to hemifacial spasm. So this is what is called a neurovascular conflict. So whenever we see a patient with hemifacial spasm, we have to image these patients. Now, these are the many phases of hemifacial spasm. It's a whole list of differential diagnosis for unilateral facial spasm. It can be idiopathic, as we see, 62% of the cases is idiopathic. Or Bell's or facial injury, this can lead to synkinesis, leading to something which is looking like a hemifacial spasm or a facial tick occurring on one half of the face, so making it look like a hemifacial spasm. Then another facial spasm is the benign essential blepharospasm, which my a young oculoplastic colleague called it when blinking becomes disabling. So here what is happening is that there is excessive involuntary bilateral lid closure, primarily involving the orbicularis oculi. The spasm disappears in sleep. Now, this is important to differentiate from the hemifacial spasm, which is there even in sleep, and this disappears in sleep. In between the spasms, the eye is able to open, but sometimes this can be in association with apraxia of the lid opening, where even after the spasm has ended, the person is not able to open the lid because of the associated ALO. So this could be genetic. And of course, before we say that the patient is suffering from benign essential blepharospasm, we have to rule out underlying ocular conditions like dry eye, blepharitis, keratoconjunctivitis, So there could be just photophobia and blepharospasm, and we might be thinking something else. And very rarely, there might be some changes in basal ganglia. Mostly, this doesn't require any imaging, and it is what it is. So few of the questions that we should ask these patients with the facial spasm is, how does it worsen? And how is it improved? So these patients with benign essential blepharospasm, it's triggered by tension, by bright light, by anxiety, fatigue, tiredness. All this increases it. But it can be read by sensory tricks. Sensory tricks like just pinching the brow area, or some grimacing, or whizzing the lids. But that is again only temporary. So mostly it is idiopathic, occurring more in females, in middle-aged to older adults. Secondary causes could be due to cerebral hemorrhage or infarction or different other causes. Women are more affected, mostly seen in urban population. Again, so what are the red flags and the atypical features? So we have to look for other associated neurological signs, because we have to treat the patient in toto, not just the eye. So we have to keep a watch for other signs and symptoms of any neurological disease. So the red flags in case of a blepharospasm would be onset at an unusual age. If a younger individual is having something like a 25 to 40 years old, we should think, that maybe something else is the cause. And it might also point towards a psychogenic spasm or some other specific syndrome. And then the history of specific medications has to be taken. Sometimes antipsychotics, etc., lead to tardive dyskinesia, certain kind of dyskinesia as a result of the medication. So whenever we are treating these patients, the first thing to do would be to stop pre-existing all these medications which have been taken, because we don't know what is really causing it. And the symptoms that do not disappear during sleep is highly suspicious. So if the symptoms do not disappear during sleep, we have to look at a diagnosis again. And again, if you give a local anesthetic drop, topical anesthetic drop, and to relieve this, and the spasm relieve, where the cause was. It was in the eye, probably a dry eye or a MGD or anything. So this chart shows how to differentiate between hemifacial spasm and blepharospasm. This is important because in hemifacial spasm, we will try to image the patient, do MRI and MRA, and look more deeply into it. So HFS, that is a hemifacial spasm, is unilateral. The blepharospasm is bilateral. HFS persists during sleep. Blepharospasm disappears. HFS is due to neurovascular compression. Blepharospasm is a dystonia, and imaging is needed in HFS, and it's not that needed in blepharospasm unless until you have those red flags. So apraxia of the lid opening, this many times it is present along with the blepharospasm. So in a patient with blepharospasm, the patient has the spasm goes, and still the patient is not able to open the eye. You should think of that there is added component of apraxia of lid opening. It's usually seen in even older adults with the peak onset in the 50s, 60s, and 70s. And here the patient is having a difficulty in overcoming levator LPS inhibition. So what happens? What does the patient do to relieve himself? He tries to manually open the eyelids, pushes the face backwards, the head backwards, tries to open the eyelids himself. And it's very rare to have a pure apraxia. In fact, it is said that it isn't exactly the right word for it. Something like a writer's apraxia. The patient wants to write, the intent is there, the patient, the muscles are there, the nerve is okay, the patient is not able to write. But here there's also a component or some amount of dystonia of the orbicularis also is there. So to call it a pure apraxia would not be correct. So this is a video of a patient. So you see that in this patient has to lift up his eyes. He's not able to open that. There's no spasm, but the patient is not able to open his eyes, and he has to lift it up manually. So this is an example of an ALO. So whenever there is the presence of an ALO, we also have to be concerned that there might be some extra pyramidal, this might be a sign of extrapyramidal disease like Parkinson's. For example, the basal ganglia is also responsible for initiating voluntary movement. And if there is a problem here, that could lead to problems with opening, problems in keeping the eyes open. So it could be a sign of an extrapyramidal problem. And we have to look into other signs. We should look into the gazes, whether the vertical gazes are okay. And then we should look for any tremors or any rigidity or any slowness of gait. So in other words, look for other signs and symptoms of neurological diseases, like in which involve the basal ganglia, like Parkinson's or maybe a PSP also. So Mead syndrome is basically dystonia, which is involving majority of the facial muscles. So it includes it includes many of the muscles, the oromandibular region and the neck region. It means that there's some kind of a widespread neurological problem. And age is an independent risk factor, 6 decade average age of onset, and it's more common in females. Again, this can also be a reflection of an underlying widespread neurological disorder or a manifestation of tardive dystonia as a result of taking antipsychotics or neuroleptics. And there's impaired primary motor and ventral premotor cortex activity. So this is just a picture of a patient with Mead syndrome. You can see the blepharospasm is also there. The blepharospasm is there. You can see that the masseter muscle is contracted, the temporalis is contracted, all the muscles are contracted, and the whole face looks a bit contorted. This is a segmental dystonia. So how do we manage these patients? First is the medical management. Apart from the medical management, I would like to say that because all these patients, the bright light aggravates all these spasms. So it's good, if we are able to give them tinted glasses, give them some lubricants, see if there are some dehumidifiers, all these things help in managing the patient. Then, of course, this is a whole lot of treatment, which is usually given by the neurologists. The mainstay of treatment, of course, is botulinum toxin. So how does it work? It blocks the acetylcholine release, causing a chemodenervation and leading to relaxation of the orbicularis oculi. It's indicated in hemifacial spasm, but we have to be sure that we have imaged the patient and there is no other problem only then. Or maybe the patient doesn't want some massive brain surgery where decompression of the nerve is taking place. And then in that case, of course, you can go in with botulinum toxin. So it's indicated in hemifacial spasm, in blepharospasm, and surgery unfit patients. Duration, it lasts for around 3 to 4 months. Repeat injections may be required. Complications are ptosis, lag ophthalmos, dry eye, or epiphora. It's preferred because it's an OPD procedure. So there are different algorithms of how the injections are going to be given to the patient. But this is one such. In benign essential blepharospasm, you can see that one is given over the glabellar area, and the upper two injections are given in the medial and the lateral area, and not in the central area, so as to not affect the levator and cause a ptosis later on. And there are three injections which are given near the lower lid, and the one near the inner canthus is slightly away, so as not to cause, so as to not affect the inferior oblique and to have problems of diplopia later on. In case of a hemifacial spasms, a few injections are given over the facial muscles also, which are contracting, but not near the orbicularis oris, that is near the angle of the mouth, because we don't want saliva dribbling later on after the injections have been given. So these are the general recommendations. It's the 2 ml, the Botox is diluted in 2 ml of 0.9% saline, and 0.1 ml is given at the different sites of injection. So it can be kept between 2 to 8 degrees centigrade for up to 24 months. At our place, we keep it in the non-freeze area for a month to be used for topping up of the same patient. And then it's used within 24 hours initially. And the Botox is taken in a tuberculin syringe with a 30 gauge needle, and the injections are directed away from the center. Now, this is one of the patients who was having hemifacial spasm, was given Botox initially, but could not afford Botox injections repeatedly, so went in for a myectomy. So you can see the scar in the picture next. Surgical treatment is myectomy with tightening of the levator tendon that elevates the eyelids, also called aponeurotic ptosis repair, and blepharoplasty can be considered for refractory cases. So sometimes a frontalis sling operation is performed as a last resort. Sometimes what happens in blepharospasm, the Botox doesn't work, then maybe you have to augment the injection, the effect of the injection, by maybe a myectomy or a frontalis sling. Deep brain stimulation or a microvascular decompression is done whenever there is a microvascular conflict in patients of hemifacial spasm. So this is just a recap of the differences between eyelid myokymia, benign essential blepharospasm, and hemifacial spasm. If in case they can also be hemifacial myokymia, where you have the small twitches in one half of the face. So to differentiate it from hemifacial spasm, in hemifacial spasm, you just saw in the video that the angle of the mouth got this change in expression, and the myokymias are just small. They don't lead to closing of the eye or any such more movement of the muscle. So triggers for eyelid myokymia are stress and fatigue. Imaging is required only in refractory cases. In benign essential blepharospasm, not much imaging is required unless until we have some red flags. In hemifacial spasm, of course, MRI and MRA would be advised. So the take-home message is not all eyelid spasms are blepharospasm. We image when atypical, treat when necessary. It can be conservative or surgical, and botulinum toxin is the mainstay of treatment. Thank you.
Thank you, ma'am, for the wonderful lecture. You have covered everything under the umbrella about the blepharospasm and facial spasms.
Doctor, please stop the presentation, please.
To that.
It's all the time saying we were able to hear the thing because it was showing unstable connection and all that.
No, nothing. Everything was fine. Can you hear me, ma'am?
Yes.
Yes, no, ma'am. Your connection and everything was fine, and we could hear you very well. So, thank you very much for accepting the invitation. Firstly, and secondly, a few questions, ma'am, regarding the management. So, usually the postgraduates in their exams will be asked what would be the management approach if the patient presents with blepharospasm. So, should they advise MRI in each patient? How they have to go about?
So it depends upon, so that is why we had this chart, showing the differences between all the kinds of facial spasms. So for them, for the postgraduates, I would say that they are okay for benign essential blepharospasm. There is mostly it's idiopathic. There is no underlying cause, and they need not image. But a hemifacial spasm should definitely be imaged. As far as the imaging is concerned, and of course, and another thing I think I missed was that ALO, for example, can be associated with can be a part of can be part of other neurological conditions that has ruled out. So what I was just trying to say. So as far as management is concerned,
Yes.
can you hear me?
Yes, we could hear you. In between, there was some glitch. Otherwise, we could hear you now. So, ma'am, what is the dose of Botox that you give at various sites, and also how do you plan to repeat the injections, and how many maximum injections do you give in these patients?
So, within the next 3 months, maximum of 100 units. And 0.1 ml is given at each site. Mostly these injections are given by the oculoplasty people in our department. So that is what I have seen them do. They give 0.1 ml away with the 30 gauge needle, tuberculin syringe away, not towards the center. And it comes in vials of 50, 100, and 200.
Yes. So, how many times do you repeat? Like 10 times, 15 times, also sometimes patients need it. So, how many maximum times you have given?
See, once one vial is open, if we have to top it up, we use the same vial for that patient. We don't use it for another patient. We keep it there. So what I've seen is that we have repeated not that many times, definitely, but definitely 3 to 4 times.
Okay. Okay. So, after fourth time, does the spasm reduce to an extent
If
that
it does not, then we have to think why it is not.
does not?
Yeah.
Yes,
So maybe
exactly.
we have to think, or maybe there is some another component of ALO. Suppose there's a blepharospasm, then there is another component of ALO with it. Then ALO might be there along with the blepharospasm. The apraxia of lid opening might be there along with the blepharospasm. Then you have to, top up the blepharospasm, the Botox with something else.
Yes.
Maybe a sling or maybe a myomectomy. Can you hear me?
Yes.
Can you hear me, Dr. Gunjan? Can you hear me?
So, so there is, the sensitivity reduces and the efficacy of the toxin reduces. So that
Yes, the
also
antibodies start to develop.
Right.
The antibodies start developing, so the efficacy might decrease.
Exactly. So that is to be kept in mind while we are giving the injections. I think very well shown that of sites. So that I think postgraduates.
I can't hear you, Dr. Gunjan.
Yes, actually my connection was weak. So I think the postgraduates should know that what has to be the dose and what are to be the sites that has that the toxin
Yes.
has to be injected.
So they have to know why we are
take
giving the
a
injections
full-
where we are giving.
Yes. And another thing that they have to keep in mind is that they do not have to inject it on the medial side and the lower lid to avoid the medial ectropion, and in the
Yes.
upper lid they should not give it on the midline to avoid the ptosis in the
Ptosis, yeah.
ptosis in the post-injection period.
Yes.
That
Because
is
you don't want
usually
to inject it.
exactly. So the most common side effect of or the most common complication of giving botulinum toxin is ptosis, which is usually transient in nature. That should be known to them, I guess.
Yes. Yes. The lymphedema also, sometimes
Yes.
lymphedema happens. All that resolves.
Yes.
That the ecchymosis and all that resolves. Maybe a few cold compresses and all. That will
Yes.
resolve it. I wish somebody would have asked me this question, that if we are in a myomectomy, when we are, removing so much of the orbicularis
Yes.
to treat this condition, then how is the lid closing then? So it's
Definitely.
because the inhibition of the levator, causes it to close. I'm so sorry, because there has been so much of unstable connection that I've been jumping from one slide to
Yeah, the presentation was very nice, ma'am. You have covered everything about the facial spasm. I think nothing more is left to discuss about it. There were some questions which we discussed right now. So I think we can conclude the lecture with this note. So this is the certificate from the DOS for your lecture. If you attend the DOS, which is being annual DOS conference, which is there from in March, you'll get the framed certificate of the same. So
Thank you so much. I had told
Yes, thank you so much, ma'am, for being. Yes, thank you so much, ma'am, for being with us and preparing the lecture and efficiently delivering the lecture and in such a nice way, ma'am. Thank you so much for taking all the time and effort. And I think Dr. Praful is traveling, so he's not been able to join the lecture, but he has asked me to convey his regards to you as well.
Actually, that problem has been with me also. Somehow I've taken out the space.
hello.
For this.
I think with that we can conclude the lecture, Gunjan.
Yes. Thank you. And
Thank you,
good night.
everyone.